Welcome back to UC Davis Live, COVID-19. I'm Satirius Johnson. It's a little over 6 months since the state of California issued a stay-at-home order, and UC Davis treated the first case of community-acquired COVID-19. What have we learned over the past 6 months? Where are we in the course of this pandemic, and what lies ahead? This week, we hear from two UC Davis experts who have been in the lead working to treat patients and prevent the spread of COVID-19. Dr. Allison Brashear is Dean of the UC Davis School of Medicine. As Dean, she oversees one of the nation's top research, academic, and medical training institutions with more than 800 full-time faculty, about 460 students, and more than 800 trainees in graduate medical education. Dr. Dean Blumberg is a professor of pediatrics and chief of pediatric infectious diseases at UC Davis Health. His interests are in preventing and treating childhood infections, vaccine research, and childhood immunization policies. And before we get started, I'd just like to remind viewers that this is a free webcast. You can watch it live and watch it after the live broadcast on the UC Davis Facebook, Twitter, and YouTube channels. We are aware of others posing links saying that you have to pay to watch this video. Please do not click on those links. This is a free webcast. And we are taking audience questions. So if you are watching us live, just leave them in the comment section and we will work in as many as we can. So Dr. Blumberg, let's start with you. What have we learned in the past 6 months about this pandemic, how to prevent it and how to treat it?
Yeah, thank you. I think what we've learned is a whole lot. Remember, we started from zero. We didn't know anything really about this at the beginning. And so a lot of the advice that we gave initially was not right. And so we've learned so much about this. Initially, remember, we were talking about don't wear a mask, if you can believe that. That's hard for me to believe considering what life is like now.
Right.
And then we learned that masks work. That's a scientific fact. We've got good information that masks actually work. The social distancing works. And initially, remember, we were focused on fomites. We were focused on touching things and hand washing and worried about the mail and groceries and transmission in that way. And it just doesn't, it's not transmitted that way. Or if it is transmitted that way, that's really minor. It's really via the respiratory route. So I think we've come a really long way in our understanding of how it's transmitted and how we can best protect ourselves and others.
Right. And I think it's so important to talk about that a little bit because, sometimes people, they get frustrated because we're being told one thing one day, and then a few weeks later, we're being told something else. And, it goes on, it kind of applies to so many areas of science, whether it's nutrition or exercise or anything, because we are learning things. So I think it's a very important point that, this is a new virus. And some of those early recommendations were based on, other older viruses that we already knew about. And with the assumption that, well, if this new virus behaves the same way that these past viruses behave, then this is the protocol. This is how we should behave. But because this is a new virus, we are still learning. And even to this day, we're still learning. Is that right?
We still are learning. And if you think of some of the stuff that comes out, like, for example, with nutrition, that you should eat that or you shouldn't eat this, that advice does evolve over time, but it's very slowly moving because we've been studying it for so long. This has been a very short timeline that we've learned about the transmission, the complications, who's at risk. And then we're still learning so much more. I mean, the multi-system inflammatory syndrome in children, that just came up in the past few months. So that was something that we needed enough people to get infected that we would start seeing that and start studying that. So there's still more to learn. So I'm sure the advice will continue to evolve and change.
So just to be clear, at this point, as far as preventing it, we're talking about the respiratory route is the primary way that the virus is transmitted. Is that correct?
Absolutely.
We should still be wiping things down as well, though.
Well, it's not wrong to wash your hands. I mean, I wouldn't discourage people from washing their hands and keeping clean, but really the primary way to interrupt transmission is via the respiratory route. So social distancing and masking.
Right. Okay. And then as far as treatment goes, where are we? What have we learned over these past 6 months?
Well, I think we've learned about the remdesivir, that works. That has some positive effects. So the specific antiviral therapy is effective. We've learned that steroids, if given at the correct time during the illness, can decrease the inflammation that sometimes goes overboard and results in clinical worsening. And then the other therapies really have not been very useful. Many of them are still being studied, and that supportive care has really improved over time. So the supportive care for patients who need a ventilator or respiratory support, that's improved over time also.
Right, okay. How has this disease impacted your patients compared to, say, the diseases you see every year, like the flu?
Well, for my patients and treating pediatrics, of course, we haven't had that many, we haven't been as affected as the adult population. But for the pediatric children, we've seen children admitted to the hospital with severe acute infection, and then we've also seen patients admitted to the hospital for the multi-system inflammatory syndrome in children. And that's a post-infectious phenomenon. And those kids are scary sick in the ICU, and that occurs generally about 3 or 4 weeks after infection. So that's something we're very concerned about.
What's the latest information we have on some of the factors that put people especially at risk of of severe disease?
So the risk factors for severe disease are very similar to what we heard early on with this pandemic. So older age is a risk factor, and anybody with a comorbidity, anybody with any underlying illness. So heart disease, kidney disease, diabetes, those are the main risk factors.
Right. We are taking audience questions, so if you're watching us live, just leave them in the comments section and we will work in as many as we can. Dr. Bashir, can you give us an overview of how the UC Davis School of Medicine has pivoted its research to COVID-19 over the past 6 months?
Well, as you know, we had the first community-acquired case on February 26th. On March 2nd, we put all hands on deck across all the campuses to really dive deep into the COVID research. We stood up 2 trials. One you mentioned, 2 remdesivir trials within 5 days, and stood up a test within 12 days of our first community-acquired case. So that was in March. I'm pleased to say now that we have had over $14.5 million of funding across UC Davis. The School of Medicine represents $9.5 million of that funding. Just yesterday, I learned that we enrolled over 200 patients in the Pfizer trial. Let me just step back a second and talk about that particular trial. We had 3,500 individuals sign up to possibly be in that trial. And it represented a diverse population across California. And about 30% of the people enrolled were Latinx, and about 12% were from the African American population. This is unheard of in clinical trials of having such a diverse population. And it's really a demonstration of the strength of UC Davis and the School of Medicine working with the community. And it's a strength of the community reaching out. You know, COVID has taught us one thing. I think everybody in the community wants to give. They want to give, they want to participate to try to find. And early on, I know, Dean, that you had those the transfusion things where people were giving blood if they had been affected. So it's just been overwhelming, and it's changed the dynamics of UC Davis School of Medicine research.
And this clinical trial you're talking about is for a vaccine, correct?
Correct. It's for a vaccine. It's the Pfizer vaccine trial that's gotten a lot of press over the last couple of weeks.
And can you just talk a little bit about why it's so important to have diversity in your pool of people who are participating?
So when you do a clinical trial, you want to make sure that the trial is relevant to the population that you serve. And so in the country, we want clinical trials of all types to represent the diversity of our country. And so that's what's so important about what we've been able to achieve as a participant in this particular vaccine trial. It also sets the stage that volunteering for clinical trials is one of the things that you as a citizen in our country can do to give back. And it's particularly important. I myself have participated in clinical trials. And if you log on to Dean's Discuss, which I believe is also on this channel, you can hear Dean Larimore, the Dean of Vet School, and myself talk about clinical trial enrollment on this week's Dean's Discuss podcast.
Right. What would you say are some of the key milestones for UC Davis over the past few months?
So I think the most important is the excitement about the intra-departmental, intra-school, multidisciplinary collaboration. So just to take it back to our testing. We worked with the basic scientists to grow the virus. We pivoted over to the people who could develop the test, and they've been working now on other tests, particularly one that's going to go live on our main campus. So it's been really, it's a true example of a learning health system. You know, it's really key that the schools of medicine are where new science is generated, and COVID has just given us a great platform for demonstrating how the strengths of a school of medicine can really improve health in the community.
That's great. And being a hub where people from different disciplines can come together and collaborate and be creative and kind of think outside of the box to find solutions.
Right. It's bringing people together, but also to put a finer point on it, we mentioned the remdesivir trials. So we had several of the large remdesivir trials in our hospital. You couldn't get in those trials if you weren't a patient in our hospital. And at times, those were the only ways you could get remdesivir, which is really the only drug, I believe, Dean, that's been shown to decrease the time that you are severely ill with COVID. So that is key. I mean, when you go to a health system that is part of a school of medicine and is active in cutting edge research, you get treatments that you wouldn't get otherwise by going somewhere else.
Right. Speaking of that, we do have a viewer who's asking, Robert from Facebook is asking, are any over-the-counter supplements or drugs showing any effectiveness in prevention?
I'll take a swing at that one. I'm not aware of that. So they are being studied, and several things are being studied. There's several theoretical reasons that some of these supplements might work, but so far I'm not aware of any evidence that any of the over-the-counter medications or supplements are beneficial in either prevention or treatment.
Okay. I'd like to hear from both of you on what your assessment is right now of the state of the pandemic on different levels, whether like locally in our region, in California, nationally, and worldwide. Where do you think we are in this pandemic?
Well, I can go first with that. I think I consider this the relative calm before the storm right now. We know what works. We know that the social distancing and masks does prevent infection and can control transmission within the community. And we had an increase in transmission when we relaxed some of our social distancing rules after Memorial Day. But now in Sacramento and in California in general, we've relatively controlled transmission so that the R naught, that's the number of patients that each infection is transmitted to, is now less than 1 for most of the state of California. Being less than 1 is important. Obviously, if every case is transmitting to more than 1 case, you're going to have increasing number of cases. If you can get that less than 1, then you can get control. And eventually, if it gets low enough below 1, you can have infection die out. So right now, it's been hovering around 0.9 and change for most counties in California. And that's good, but we're entering the winter respiratory virus season. And we know that this virus traditionally has enhanced transmission in the winter. So we do expect an increase in cases throughout the month of October, and then a real increase in cases in November. That's what we're worried about.
Right, because most people are going to be inside more, and we're going to be sharing air with other people more.
Right, so it's easier to transmit indoors because there's a limited volume of air, whereas if you're outdoors, there's basically an unlimited volume of air, and that dilutes the virus, decreasing risk of transmission. Plus, in the winter, the temperature and the humidity favor survival of the virus so that you can have enhanced transmission.
So I think one of the things is that people are taking this as the new normal now. We're about 6-7 months into this, and everybody expected things to one day they would wake up and things would be back to normal. That's not going to happen. But I do think that we are going to need to be continually vigilant. So we see where Dean mentioned masking. We see where suddenly people are wearing masks, and then the next week not so much, and then not so much, and you have to re-educate, re-engage on these simple things: masking, hand washing, social distancing. I don't think that there's going to be just a magic day when we wake up and this virus is gone. It's going to be kind of like the flu. It's always going to come around, and until we have a vaccine, it's going to be paramount on each of us to do that. And we're trying to reinvent things in real time here. Education is a big issue. I know going back to school is a huge issue for families.
Yeah, I think it's part of human nature to just kind of, people get fatigued of kind of, practicing these things that are just not part of our normal routines. I mean, now they are becoming that, but you kind of let your guard down a little bit, and maybe you leave the car without your mask and you got to go back to the car to get your mask. And, it's very difficult. So, I mean, that's part of the challenge, is kind of just the human behavior part of it, just changing our habits.
We haven't been, as a country, very aware or really supportive of public health. And now public health is at the first front. It's right front and center. So you mentioned R0, Dean. I suspect there's more people now that know what that is across the country. And people didn't know what the NIH was. They didn't know who the CDC is. And, I think Tony Fauci is one of the most recognized people in the country now. And so it's really brought science to the forefront, and the dependence that we have as a country on being healthy with having science side by side at us. And, if there's a good thing to come out of all this terribleness, is the fact that we've recognized that our survival is based upon staying ahead of with science and partnering with science.
Let's talk about our assessment. What is your assessment as far as the pandemic nationally and worldwide? Because we are all connected. We live in such a connected world right now. What happens in Sacramento could have an effect to what's happening in Kansas or New York or, Beijing. So, we're all in this together. So what is your assessments of the state of the pandemic nationally and worldwide?
I'll take a stab at that one. I think we're going to continue to see the ups and downs. Just this morning, I heard there were uptick in some cases in Europe, and the states are up and down. And from a personal level, I have a son in New York and a daughter at Chapel Hill, which has made a lot of headlines. And I think the onus is going to be on all the communities to stay very vigilant and really enforce social distancing and masking. Because whenever we let up, it goes global. And, you can almost see, Dean, I'm sure you have a ton of maps where you can see how things move across the world and then back again and up again. So it's a global disease. It's not a Sacramento disease. It's a global disease.
Yeah, I would totally agree. We're all connected. It's one world. Even with travel restrictions and decrease in travel, we're all related. And so that's why it's so important to have international cooperation to really attack this disease. And that's going to be especially important when we do get available vaccines in this country and worldwide. As long as there's transmission anywhere in the world, we're going to be at risk. And so that's why we need to really help others to control transmission and to decrease risk.
We have a question from a viewer, Servando on Facebook. He's watching on Facebook. He says, I heard that the CDC said that this virus is not an airborne virus. There's that whole kerfuffle with the information going up online and then being taken down and going back up again. So he's asking, is that true? And I think you can reiterate what you said earlier in our conversation here, I guess.
Yeah, that whole episode last week was unfortunate. The CDC in general is very good with clear and consistent messaging. So that was a misstep to post that and then to withdraw that. The scientific evidence isn't 100% clear on aerosol transmission. We've generally been focusing on droplet transmission. These are relatively large droplets that when you're speaking or coughing or sneezing, they're heavy enough that they don't stay suspended in the air. They can only travel about 6 feet before gravity takes over and they end up on the ground. So that's why we have these social distancing rules for 6 feet. But if there was only droplet transmission, then wearing a mask and social distancing would work 100% of the time. And we know that doesn't work 100% of the time. And we know, related to other outbreaks that have occurred, many people might have heard of the choir practice outbreak that occurred in Washington state, where people were distant from each other. And there was a lot of transmission within that choir practice for people more than 6 feet away. So there probably are events, opportunistic events that may occur from poor ventilation person or singing or maybe crying or talking loudly that will result in aerosolization. That's probably not as important as the droplet transmission. So we know wearing a regular surgical mask can decrease transmission by about 2/3, and that doesn't protect against aerosols. So there's more transmission that does occur besides droplets, but really the low-hanging fruit, what we can all do is prevent droplet transmission. And once we can control that, then maybe the next step, I think it might evolve into attacking aerosol transmission.
Amber, who's watching on Facebook, is asking, how can you say we know that it will be transmitted more in the winter? This seems like it's comparing it to the flu, but it's not the same virus.
Yeah, so coronaviruses are similar to the flu, influenza virus, in that they are transmitted more in the winter than the summer. I think the reason that we had so much transmission in the summer is because virtually everybody in the country was susceptible to the virus. So this was similar to 2009 when we had influenza H1N1, which started in the spring. And then we wondered if there was going to be transmission over the summer, since it is a traditional winter respiratory virus. And what we saw was sustained transmission over the summer because so many people were susceptible. But we do expect an uptick in transmission, more favorable conditions for transmission in the winter for the novel coronavirus also.
But if I could just jump in here, Dean, it is so important people get their flu shot this year, because, and we're actually in our UC Davis Health emergency room, we're going to be starting to test for the flu and COVID at the same well, because it's going to be hard to tell who's got what. And so having the flu shot will be so important, because Dean, I would imagine that someone would get really sick if they had the flu and COVID, right? You could possibly get both at the same time.
We know that people can get both at the same time. That's such an important point. And there's emerging research just published this week from the UK that shows if somebody has COVID plus the flu, they're more than twice as likely to have a severe outcome compared to just having COVID alone. So we know that that increases risk of severe disease.
We have another question from a viewer. John, who's watching on Facebook, is asking, how safe do you both believe it is to fly right now? Any advice for a cross-country flight?
Sorry.
I can just speak from my personal experience, which I haven't flown since this all started, but I've seen the advertisements from the airlines. I've heard from other people who've been flying. Most of the airlines are keeping the middle seat open. The ventilation systems on the airplanes are excellent. Most of the airlines are enforcing the mask wearing and the social distancing, both at the gate and on the airplane. So, I've started considering flying if there was anywhere to go to vacation.
Right.
I've started considering that. So I think it's relatively safe. It's still safer if you want to travel to drive.
So I wonder, I think the biggest risk is being in a small room with 20 people who aren't wearing a mask and are eating and talking loudly. That would probably be a bar, right?
Right.
Or inside of a restaurant is probably much more risky than to be inside an airplane with the HEPA filters. But your safety is also dependent on the guy next to you, or not having someone next to you in the middle seat. So we flew both of our kids back to the East Coast for school. And then of course, most of school is virtual.
Right. And I believe, something I learned in this pandemic is that apparently half of the air that you breathe on an airplane is actually coming from the outside, and only the other half is being filtered through HEPA filters. So, as far as ventilation goes, that is actually a pretty safe, system.
Right.
We're hearing a lot about when a vaccine or vaccines might be available. What are your expectations about the timeline?
I've been expecting, based on the intensive worldwide effort to develop vaccines and a lot of efforts and a big push, by the time you get the data, analyze the data, you're able to present the data to an advisory group to the FDA, and then have the FDA meticulously go over the data and get the vaccine approved, and then manufacture the vaccine and distribute the vaccine. You know, I just don't see that this is going to be available in this country before next year. You know, hopefully early next year, but I just don't see it being available this year in any sort of widespread manner.
You know, we might want to talk a little bit about the important role of these studies and how regulated they are. So, you know, the FDA really oversees these studies. So the studies, for example, in schools of medicine across the country, including at UC Davis, have regulatory bodies within our school, regulatory bodies within a broader called Central IRB. They oversee all of the enrollment criteria, safety. There's a data safety monitoring board, which is an external body, and then there's the FDA. And so that's what makes these research studies, whether it's COVID or anything else, so safe. The other thing is there's lots of safety visits built into these. So, you know, if I go to the doctor and I just see a doctor and they give me a regular drug and they say, oh, okay, I'll see you back in 6 months. Let's say I'm a neurologist and say it's for epilepsy or migraine or whatever. You know, you try this, I'll see you back in 6 months. Let me know how you're doing. In a research study, it's completely different. They give you a drug and then you're seen back sometimes 2, 4, 6 weeks. You have lots of visits. Many times now they're virtual, lots of check-in, lots of blood draws. So there's a lot of supervision. I would venture to say that the quality of care that you get in a research study and the intensity of oversight that you get in a research study, particularly a phase 2 and phase 3, which are leading to FDA approval, is probably far better than you get just in a routine doctor's visit. There's just so much regulation and so much oversight. And that's why I really think it's really important for people to volunteer for trials. In fact, we have electronic study pages that you can volunteer for clinical trials across any disease, not just COVID.
Cindy, who's watching on Facebook, asks, what's the best time to get the flu shot? My 80-year-old parents were going to get it now, but heard better to wait till late October, so it will last longer.
So once you get influenza vaccine, it takes about 2 weeks for your immune system to develop the immunity so that you are protected. So you want to get it in advance of when flu is being transmitted. But that's like trying to predict the stock market, really, because it's different every year. We know that in most years, the most common month that there's peak influenza activity is February. So you certainly want to be protected through February. And the immunity that you get from the vaccine lasts 5 to 6 months. So in general, I recommend people get vaccinated as soon as the vaccine is available so that you don't procrastinate and then miss the window of opportunity to get vaccinated. But you know, I've heard lately different messaging from people like Dr. Fauci recommending immunization in October. So that you can really maximize your immunity during the peak months. So you'll see different recommendations as soon as it's available or October. And I would say October at the latest. I wouldn't go beyond that because you don't want to miss being vaccinated before the season starts.
So if you can get it now, basically.
Right, exactly.
And you can get it now. We've just started vaccinating, and I'll say that we are having everybody at all the UCs across the state be vaccinated. And you know, that says a lot about what we at UC think is important. And we just think it's really, really important that everybody get vaccinated. We can't have our workforce get sick. That would be terrible. Everybody needs to get vaccinated.
Dan, who's watching on Twitter, what are the current recommendations for touching surfaces and why have they changed since March?
Well, initially we had some research showing the survival of coronavirus on surfaces that depending on the surface, it could last for hours to days. And there was a lot of concern that there would be transmission that way. And so what we've seen is a lot of disinfection of what we call high touch surfaces, such as doorknobs. We've seen businesses, when they've had a case of COVID in an employee or a customer, they've closed and they've gone through what they call high-level disinfection and a deep cleaning. And I think a lot of that is for PR purposes, really, just to reassure the public that it's a safe place to go. But we know that the primary route of transmission is the respiratory route. We think it's great to wash your hands and carry around a little alcohol hand gel with you when you do touch high-touch surfaces such as doorknobs, elevator buttons, mailboxes, all those kind of things. We think it's important to do. But I think it's more important to prevent other things like staph infections than actually COVID. So it's great that people are paying more attention to hand sanitizer and washing their hands more, but I don't think it's having an appreciable effect on preventing COVID infections.
Dana on Facebook is asking, should students be going back to school now in a community with low spread? She says, our schools are old and do not have full HEPA filtration.
Yeah, I'll take a stab at that too, which is, it is kind of an odd thing when we're talking about trying to control transmission in a community, and then we're saying, hey, and let's open the schools where kids and teachers are going to mix from different households. And the concern is that this could lead to increased risk of transmission, not only for those children and teachers, but then they could spread it throughout the community. But we do have some good evidence that you can open schools safely. The first thing that you need to open a school safely is you need control of transmission within the community. And then what you need are rules guidance to limit interactions at the school. So have smaller pods of children, not going in between classes, not congregating all together at lunch in the cafeteria or recesses, but really remaining within their pods, and then really having robust testing and contact tracing available within the community. And we've seen schools that open under those conditions do not have an appreciable increase in rate in transmission. What we've seen is if you don't do that, if you open a school when you don't have control of transmission in the community, and when there's not robust testing and contact tracing available, that does result in increased transmission. So you have to do it right, and you have to do it when the conditions are right.
Isn't it also to the parents? So if you control at the school, but you go home and no one's wearing a mask and the parents have gone off to work or whatever and not worn a mask, and they're coming back in and the children come back in. So, one of the things that's been, a challenge is you control in one environment, for example, in the hospital, but then people go to the grocery store and they don't wear a mask. So it's not, it can't do it 50% of the time. You have to do it 100% of the time, unless you're in your home with your own people.
Exactly.
It's like we're only as strong as our weakest link, basically.
Yeah.
That's a good way of putting it.
Weak link. Yeah. Okay. Monique on Facebook is asking, having worked in research for years, you know that pharmaceutical clinical trials take years. Do you have concerns that these vaccines will be fully vetted for adverse effects?
Well, I think we're seeing that. And we saw, for example, with the Oxford AstraZeneca vaccine, where there was a serious concern of an adverse effect in a woman in the UK, that they just stopped the trial. They stopped enrolling because they were concerned about that. And that's the normal thing to do. I've been a principal investigator in vaccine trials. And as the principal investigator at a site, if you have a study participant have any concern about a serious adverse effect, then as the principal investigator, you delve right into it and you get all the details you can to try to determine causality. Is it likely to have been caused by the vaccine? Is it unlikely to have been caused by the vaccine? For example, what if a study participant dies, but they die because they were in a car accident? That's unfortunate, but it's probably not due to the study drug. But if something else happens, it might be due to the study drug. So I think you have to really investigate these thoroughly. And as Dr. Brashear mentioned, then you have your data safety monitoring boards and your IRBs, and everybody's looking into that to assure that it's safe to continue with the study.
So there's a regulatory oversight called a serious adverse event, or SAE. There are all kinds of rules that you must notify within a very, very short time frame. The all these people about a serious adverse event. And we saw that in this trial that actually worked. They got a serious adverse event, they reported it, and things stopped immediately. So that's the regulation. I just think that the FDA is set up for that. And, there's all these people out there like Dean and others at multiple pieces to make sure that we don't have any holes in our processes. And those processes have been around for a while. Even after things are approved, there's called after market oversight. And that's how we as a country have also caught things that have gone to market and had late things that develop. So nothing gets just approved, right, Dean? It's not approved and then bye-bye. It's approved, still watched. Yeah. And so even if something goes to market, like a vaccine, there will be such scrutiny on things, and still you can do a stop even after things go to market.
Mm-hmm. And I think that question brings up a really important point, that remember, the idea behind vaccine development isn't, for example, for me to get the vaccine and then all of a sudden like life returns to normal for me. That's not the way it works. I mean, the idea is we want to get herd immunity. We want to get the vast majority of people within our communities getting immune, getting immunized. And if we don't have full confidence in the safety and effectiveness of that vaccine, that's a problem. And that's why we really do need to be deliberate and transparent. And we want to make sure that everybody's confident that when a vaccine, or probably several vaccines, are out there, that they are safe and they are effective.
That takes us to our next question. Christine on Facebook is asking, can you speak to the different vaccine trials out there? How many distinct trials are there in the US?
Every day I hear more and more. Dean, do you know this total number?
I don't know the total number. I've been really focusing my attention on the ones in the phase 3, have made it to phase 3, really.
So how many have made it to phase 3 so far? Approximately. It doesn't have to be exact. Are we talking about a half a dozen, a dozen?
Well, if we take out the Chinese and the Russian vaccine, then that would be 4 vaccines. Is that correct?
I think that's right. And they're variable sizes. And so also to Dean's point, they need to have large numbers of patients in the vaccine trials. And the other thing I think is important, Dean, for us to say, that if you're in the vaccine trial, you get the vaccine, you're monitored to see if you have any adverse events that we've just discussed, but then you're not exposed to the virus. If you're in the vaccine trial and then you get COVID, that's something that would be recorded. But people thought, for example, Dean, that if they got the vaccine, then we went off and infected them with COVID or something. And that's absolutely not happening. Correct, Dean?
Right. That would be a very interesting study, but not one, not one that we would consider ethical. Right.
Never get it approved. So, I mean, it's really about, and that's why you need such large numbers, right? If you do the math. So you need like 30,000 people, and then you vaccinate them, and then you see in the natural course of their lives, do they get the disease? And that's why you need really large numbers. That's why I'm really passionate about getting people to sign up, because it's just in the natural course. So, if you get the vaccine and you go on and you live your life and you go to the grocery store and you go to work and you happen to get it, then they would say, okay, looking at your blood and looking at the safety, did it work or did it not? And then statistical comparison. So the real issue with the vaccine trials is getting large numbers.
Right. And that's why all these studies are multi-center too, because they need to be occurring in areas where there's transmission of virus. And as Dr. Brashear mentioned earlier, it's really spotty. Some areas it's waxing and waning. So that's why it's a multi-center study, to make sure that some of the participants will get infected. And then you compare those to those in the vaccine group versus those in the placebo group to see who's protected, and making sure you have plenty of patients, right, so that you get enough infections so that you can be confident that when you do find a difference, it's not just by chance, that's highly statistically significant.
So what's that number? I mean, Diane from Facebook is asking, how many people are enrolled in the trials to make the results statistically significant?
Why the one, how many are supposed to be in a couple of these? 30,000, 100? I mean, I've heard huge numbers.
Yeah, the more number, well, I guess I wouldn't say there's a minimum number. It depends on the follow-up, because if you have a smaller number enrolled and you follow up for a longer period of time, then you can detect a difference. So the more people that you enroll, the sooner you're going to get your answer. But most of these studies are 20 to 30,000. And remember, it's not just big numbers to detect effectiveness, but we really want those big numbers because we want to be sure that we're convinced that the vaccines are safe. So we want to make sure that there's enough people who are studied that we're confident that there's no rare serious adverse effects, because we're planning on giving this vaccine to every single person, healthy people. So the bar is set very high that we don't want to make healthy people sick by giving them a vaccine with serious adverse effects. We want to make sure that these vaccines are safe. So we need big numbers so that we're confident in that.
And, one thing that in the course of just a regular disease, let's say you're studying Parkinson's disease, you might enroll a couple hundred, then you'd look at the results and go, and then do maybe more and look at the results and finesse. The reason that there is a high number is that we want to be able to do this quicker. So the quicker you want to get the results, the more you need, right? And then also you want to be able to compare to placebo. So you want to find out whether it's by chance. So that's one thing I think that people are, so the higher number you enroll, the quicker you can get that answer. The longer the study goes and the lower number, then the longer things are going to take, right, Dean? So
yeah, absolutely.
Really, the outpouring from the community is so important to volunteer, because that's going to help us get an answer. And it's been incredible. I've just been so heartwarmed to see. And we want, and isn't it also, Dean, you want to be able to study these vaccines in people who are at higher risk, correct?
People who are at higher risk, we want to make sure, we don't want a vaccine to come out that's just for like young, healthy people, right? Because we know that the highest risk people are those who are older and with comorbidity. So we want to make sure it's studied in those populations. And then in the US, with a diverse racial and ethnic backgrounds, we want to make sure that it's studied in everybody.
Right.
Danelle, who's watching on Facebook, is commenting. She says, it's important to emphasize that safety data will take years to accumulate, correct? The first vaccines and its distribution will not help the world overcome this pandemic overnight.
Well, the safety data, there's long-term safety data and short-term safety data. And so for these vaccines, one would expect that any adverse effects that occur would probably be a few days after being immunized. It's possible, if the immune response that's elicited is not the right immune response, that you could, for example, increase risk of the MIS-C, the multisystem inflammatory syndrome in children, because that is an immunologic phenomenon. But that would be seen within 3 to 4 weeks following immunization. So I think almost all, I'd be confident in this shorter term follow-up in terms of adverse effects.
And I think we have experience with lots of vaccines. I mean, polio, smallpox, there's been lots of vaccine research. You've done it, Dean, everybody else here at UC Davis has done it. And so, it's not like we just are new to vaccine research in this country. We've been actually very successful in the country in vaccine research. Look at the flu.
Mm-hmm. We have another practical question from Sandy on Facebook. What should families do when students return home from college to protect the families? And I guess that could go for anybody maybe moving back in with a group that's been isolating.
Yeah, that's a challenge. Ideally, what you would do is have that person isolate for 14 days from the last contact, stay 6 feet away from people, stay in their own room when they're in common areas, to wear a mask. I'm not sure how feasible that is, but that's the safest thing to do.
I think that it's possible for people to be in college and have people, even in their living environment, who are positive, who have been quarantined, and other people remain negative. And so I think In my own personal life, I've learned that the importance of social distancing for these college students cannot be underestimated. And those college students who do wear a mask and do social distance and don't go out to parties and all the others can stay negative. And the ones who think it's not going to happen to them, they get sick, and some get very sick. And it's, I think, been an eye-opening, just eye-opening. And there's tragic cases we've seen recently of healthcare workers, young healthcare workers getting sick and dying. And so I can't say enough to the young people to take this seriously, very, very seriously, because even if you don't get sick, you don't want to get your grandmother sick.
Yeah, and I think you bring up another important point, which is that I think a lot of times people might feel they might let their guard down because they think I'm young and healthy and I'm not symptomatic, and the people I'm hanging out with are young and healthy and they're not symptomatic. So what are the chances really of getting it? But I think what some people don't realize is about 2/3 of people, 2/3 of the cases are acquired from people who have no symptoms. So this is very infectious the day or two before having symptoms,
Right.
so that in the pre-symptomatic state, and then even people who are infected and never develop symptoms who are asymptomatic can transmit to others. So 2/3 of infections are for people who appear outwardly, they appear healthy. So that's why it's important not to let your guard down, even if people do appear healthy.
Right. I mean, this is a contagious disease that you basically have to act as if everyone has it in order to get a handle on it. You can't act just because you look healthy, you don't have any symptoms. Asymptomatic transmission is a reality. I mean, 2/3, that's a huge number.
Right. You can't just look at people and say they're not a risk to me. You just can't do that. Everybody's a risk.
I think one of the things that I've really focused on is where you're at, indoors versus outdoors, and then how close you are to people and whether you're wearing a mask. And so one of the issues really is this whole idea of dose, right, Dean? The dose, the more you get, and the more you get is influenced by the space that you're in. So if you're in a closed environment versus outside next to a contagious person, you're going to get a higher dose in that closed environment.
Right. Indoors is riskier than outdoors. Being closer to somebody is riskier than being distant from them. Anybody who's unmasked is a higher risk compared to wearing a mask. And then the duration too. So if you just walk past somebody on a hiking trail, I don't worry too much about that. But if you're in close conversation with them for a half hour, that's a higher risk.
We have another question about the vaccine trials. Elise from Facebook is asking, what are the age groups participating in the vaccine trials? Are children included in these trials?
To my knowledge, they're 18 to 85. And typically with the FDA, they will do trials with adults. And from everything I know, there are no children being enrolled in trials. But Dean, do you know of any children's trials?
No, I'm not aware of that. You're absolutely right. The usual way these trials are done is the first studies, the phase 1 and 2, are done in healthy adults, healthy young adults, and then they're broadened to wider age ranges. But yeah, I'm not aware of any studies in children locally, at least.
There seem to have been a lot of distractions over the past few months about things like wearing masks in public or which businesses could open and when. As a nation, do you think we've been focused enough on what we need to do to get through this pandemic?
I think it's been challenging because we do need clear and consistent messaging, and ideally that would be at the federal level. So, to have the career professionals at the CDC be front and center. So I think it's been challenging. The states have been doing a lot of the things on their own, and that has led to some mixed messaging. So I think it's an opportunity for us to really refocus and really, trust our public health officials. They're my heroes, the public health officials. At the CDC, at the state level, and at the county level, they're doing an excellent job.
I think this is about leadership too, about clear messaging on what we need to do. And I think that means wear a mask, social distance, and participate in any way you can in the fight, whether you want to be in a trial, you want to give blood, you want to be supportive to those who are ill, participate in some way. And it's put a new focus on public health. So I talk to a lot of students. I'm a dean of a school of medicine, and we do education as well as research, and we take care of patients every day. The faculty are at the front line, at the bedside, in the operating room. And one of the things that we want to do is role model for the future physicians. And we want to teach them that, schools of medicine are really the intersection of education, research, clinical care, and the community. And those students are really seeing public health crisis in real time and I anticipate that there will be many, many more students who are going to go into public health. UC Davis School of Medicine is number 7 in the country in U.S. News and World Report for primary care. And primary care and being at the forefront, at the bedside, is part of really changing public health. And everything Dean's talking about is about public health. Washing your hands, wearing a mask, getting a vaccine, taking care of yourself, eating right. Those are all public health messages that sometimes we have just not paid attention to as a country.
I guess quickly, we have a question. Erica from Facebook is asking, how do I enroll in a trial?
So we will we'll put up on our website, I hope, Sartorius, we can put the study pages link, and that's the way you can enroll in trials here at UC Davis. You can also go to clinicaltrials.gov, and that has all of the NIH trials listed. And I think it's critical, if you turn into Dean's Discuss, you can hear Michael Larimore and I talking about how we've each personally participated, and even my beagle has been in a clinical trial. So, animals too can be in research.
That's great. Well, we're going to have to wrap up for time very soon. So I just wanted to briefly ask you, and I guess, Allison, you touched on this a little bit earlier in our conversation, but how close are we to finally bringing COVID-19 under control and going back to normal, or at least some sort of, I guess, closer to normal?
I don't think we're going to hit normal anytime soon. And I think the closer we get to consistent masking and social distancing, the closer we're going to get to normal. The ability to get back to what we perceive as close to normal is in our power. And that means we need to mask and social distance, and we need to be smart, and we need to take responsibility for our own health, and we need to take responsibility for the health of our community. So it's up to us, but I don't see just a wave of the wand and we go back to the way life was. I defer to Dean on what he thinks.
I don't know. I've got more questions than answers, because even when a vaccine is available, we know we're not going to be able to give it to everybody all at once. Yeah. And we know that it's probably not going to be 100% effective. So even that's not going to solve everything. It's going to improve our situation, but it's not going to return us to our previous way of life.
Yeah.
Well, I want to thank you both so much for the update. It's so important to stay on top of the latest knowledge as we continue to learn more about this new virus. And I also want to relay to you, we've been getting a lot of statements of support on Facebook and elsewhere where people are watching this. Dana on Facebook is saying, this is a fantastic forum. Thank you for holding this information session. Impressed with UC Davis as the parent of a patient cancer center and as a community member. So thank you from myself. Thank you from everyone in the community for all of your work and for sharing your knowledge.
Great. Thank you, Sartorius.
Thank you.
Dr. Dean Blumberg is a professor of pediatrics and chief of pediatric infectious diseases at UC Davis Health. And Dr. Allison Brashear is dean of the UC Davis School of Medicine. On the next UC Davis Live, COVID-19, we'll look at links between climate change and COVID-19, which is also the first topic of the second season of Unfold, a UC Davis podcast. The second season focuses on climate change with new episodes every Tuesday. You can hear Unfold on demand for free at Apple Podcasts, Google Podcasts, Amazon's TuneIn, Stitcher, Pandora, and Spotify, and it'll be soon on all Echo devices as well. Until next time, I'm Satirius Johnson, and this is UC Davis Live, COVID-19.